Hey, welcome everybody this is the 10th of our Triple ID conversations, and they've all been so interesting so far, and this is going to be no exception. I know a lot of us know Karel. He's been a specialist in medical information design since he did his PhD at Reading University, I think in 90 something, wasn't it?
93, yeah.
93, yeah.
1993 to be clear, not 18.
Okay. Yeah. And since then he's really become one of the preeminent experts in the field, and he runs his own design research consultancy in Belgium, developing and testing information leaflets and so forth. He's also a board member of Triple ID, and he's on the editorial boards of various journals, Information Design Journal, for example, and he teaches at Lucerne University in Switzerland and Hasselt in Belgium, I think, as well, Karel. Otherwise, you may have more to add to your introduction, but thanks very much for doing this, and off you go.
Wonderful, thanks so much. Sound okay? Can you hear me?
Sounds
wonderful.
Brilliant.
Thank
yes.
you.
Yeah.
Now, what I would like to do is just I've made quite a collection of examples of information for patients about medicines, and I'll show you some examples. Unfortunately, the collection of bad examples is an enormous amount larger than the good examples. So some of them just show us how bad they are at the moment. Most of them are recent. I'm not going into the history of this stuff yet, but I'll just show you some examples of what's happening in the medical world and information design. Let's see how I can go to the next slide. Why is this not working? Okay, yeah. This is the front of a box of ibuprofen, the simplest of the simplest medicine you can buy in a pharmacy or even a motorway place. You can buy these 200 milligrams ibuprofen packaging. This one is from Boots in England. It's on the front of the box. It states relieves pain, inflammation, and fever. So it tells you what it's for. But I had a splitting headache, so I need to figure out if this is the right type of box for that. So I look at the back of the packaging, and I'll see some text there. I'll zoom in on the top left-hand side corner of this back of the pack. Yeah, this one. And it states, read all of the enclosed leaflet for full instructions as the first line. I'm not sure the pharmacist would accept that I've got to take the leaflet out in the shop before I buy this stuff. So I think that advice is not really correct at that point in time. But then it states uses a slow release capsule for the relief of headaches, rheumatic and muscular pain, backache, migraine, period pain, dental pain, and neuralgia. And it can also be used to reduce fever and relieve the symptoms of cold and flu. From a design point of view, there's a hell of a lot wrong with this. It's very hard to read, even in this enlargement. Any typographer or graphic designer might start to point out that the braille dots really don't work. It actually states Boots, B-O-O-T-S, straight through the text. The contrast between the black type and the gray background is not optimal. There is very little space between the lines. The contrast between the black type and the gray background is not optimal for reading. And the gray is actually highly reflective, which makes it more difficult to read the text. The type is actually squeezed, it's condensed. And these are the 7 reasons that are common in the literature, typographic literature, absolutely don't do any of these. So I'm not sure why this is done, but the typographic literature goes completely against this. It hampers reading. But I might just be, as you suggested, a grumpy old man that was educated last century. So I look at another painkiller. This is a competitor, aspirin. This package contains 28 aspirin tablets. At first sight, there's little wrong with it. There are 7 of these blister packs inside the box. And these blisters are actually really good. They don't use any PVC, and they don't glue plastic to aluminium. So from an environmental point of view, this is fairly good. This can be recycled. But what I'm worried about is that about 1/3 of the box is the space for the package leaflet. So if you look at the box itself, 2/3 is for the packaging, for the actual tablets, and 1/3 of the box is for the package leaflet that accompanies medicines and for aspirin. That means that out of 3 containers that leave a factory, 1 container is just the information. That's simply unsustainable. That shouldn't happen. I go a bit further. Okay, can you see the difference between these 2 boxes? The top one contains 30 tablets of 30 milligrams, and the blue one below it contains 30 tablets of 20 milligrams. And when you look a little bit more carefully and look at the text, the top mentions lactose, the bottom one doesn't. The top one mentions prednisolone 30 milligram PCH, but the bottom one, prednisolone 20 PCH, where's the milligram gone? And pharmacists have to look at these boxes all the time and make absolutely sure that they give you the right box, 20 milligrams or 30 tablets of 20 milligrams. And every time the pharmacist must be absolutely right. They can't give you the wrong medicine. And I'm afraid that if you design packaging like this, it will be very difficult to distinguish and mistakes are made. One more example. Pharmacists have to give instructions to patients. And in many European countries, they simply write on the package. And I can probably see 3 times 1 here after a squiggle that I don't recognize in the handwritten line. And I can't even figure out which language it is. So it means 3 times 1, but then after that, I really don't know. It's not very helpful for patients when they arrive back home and try to figure out how to take these tablets. Should I take 3 times 1 every time, or should I take 3 times 1 at the same time? And this is actually a global problem, it's not only an European problem, it happens everywhere in the world. I've got an American example here of a leaflet that's given to patients in America by a CVS pharmacy, which is one of the larger chains of pharmacists. And I've just discussed this yesterday with an American pharmacist at a conference in Frankfurt, and she told me that this is common practice to give patients this stuff. I can see Martin cringe because it's beautifully done, isn't it? And it's wrong in all respects. It is just the text is written for. It is not written for people. This, but this is common practice in America. I go back to Europe. These are European package leaflets. They're included in Europe in every medicine box since 1999, approximately. They're folded many, many times. They use small type, they use very thin paper, and they're hard to use. One of my Swiss students in Lucerne showed me the leaflet of one of her medicines. And this is a single language leaflet. And I maybe shouldn't say it, but she's got an attention disorder. So this leaflet should be read by somebody who's got an attention disorder, which makes it, the contrast is just, it's not very good. These leaflets are getting so long and so big and so large that they don't fit in production lines anymore. The production of medicines is an enormous industry, and these leaflets need to be stuffed in boxes at enormous rates. And if you don't glue them together, the production lines start failing. So what they do nowadays, many industries simply glue the package leaflet together with transparent tape and hope that patients are active enough to try to tear these plastic tapes around medicine leaflets before they start unfolding the leaflets. The annoying thing, of course, is that this photograph shows the tape fairly clearly. But if you use transparent tape on a white background, many elderly people simply don't even notice that there's tape there. And then the second thing is they don't have the dexterity anymore to open it. So I'm fairly sure that most of these package leaflets that are glued together will not be used, will just be binned immediately. What's happening in practice is that many patients do not get one medicine, but they get 2 or 3 or 4 or 5 or 11 when you get really old. This is a table, or these are the leaflets for a diabetes type 1 patient. And these leaflets are supplied every month for the rest of her life, probably. So every month she gets all these leaflets and these boxes, and she's got to figure out how to use them. The combination of all these leaflets is just simply impossible to read. It really takes days of study to find out what's happening here, and which ones prevent you from traveling, or which ones from driving a car, or which ones should not be used in case of pregnancy. Diabetes type 1 patient. This is a coffee table of a young lady who's got asthma, severe asthma. She has to take these medicines to her work or to her study every day. And these are the leaflets she carries and boxes she carries nearly every day. When she gets an attack, she needs some of these medicines. Some of these medicines are there to prevent an attack, and some of them are there to make attacks less severe. This is the stuff she has to take and has to read every day. To give you some idea of the scale of this issue, medicines are mainly taken by elderly. That's where the bulk of the medicine goes. At the moment, we are looking at 18.5% of the population is over 65, and both are increasing. The percentage is increasing, but the age level, 65, is always, that is an arbitrary level. People start using more medicines after the age of 50, and even that age is going down because there are more preventive medicines used. So the number of people who use medicines over the age of 50 is very substantial. Functional literacy, people who can actually read texts and have with ease in their own language. On average, about 20% of any population cannot follow simple text in any language. Health literacy, 50% can't follow. That's again, it's a fairly arbitrary figure, because even if you, I just asked an audience of doctors a few months ago, just last year. This patient I just had with the insulin type 1, she's got the diabetes type 1, and she's got a thyroid problem as well. She uses oral contraceptives, and so the pancreas doesn't use any hormones. Her glandular glands here, her thyroid glands, have produced some hormones. The oral contraceptives apply some hormones, and she wants to get pregnant. And they look at this audience of doctors and they say, look, yeah, but I'm not sure what. So he asked them what they should do, advise this particular patient. And there was no general advice. So I said, look, you claim to be a health literate yourself, but I've got a very practical case, a young lady who wants to get pregnant. And you can't give an answer within half a minute. So I let them deliberate for another minute, and they couldn't find an answer immediately. This audience of doctors was completely health illiterate at that point in time. Compliance, that's how many people take the medicines. It's the wrong word, adherence, compliance, but basically, can patients take their medicines, and do they take their medicines? It's still set at 50% for chronic diseases. So for chronic diseases, half the patients take their medicines effectively, which is again a strange figure, because it's not applicable to all medicines equally everywhere. But it indicates that on Monday we produce for patients, and on Tuesday we throw the whole production away. On Wednesday we produce for patients, and on Thursday we throw the whole production away. That's 50%. And that's unacceptable, I think. Casualties, at the moment, about 1 person per million per day dies because of wrong medicine use. That's a ballpark figure again, but that seems to be fairly accurate. So in the Netherlands, with 17 million people, 17 people die today because of poor medicine use. And in Europe, we produce between 5 and 15 billion of those leaflets every year, and they're not effective. So that's simply not sustainable. That needs to change. Some leaflets are absolutely essential. Some leaflets can be deleted and be replaced by digital ones, or we need to look at combinations of digital and paper information. And that's going to be a very interesting discussion with all sorts of regulators, because they haven't thought about it yet. So those are a few figures what we're looking at. It's an enormous area, and we're not doing very many things absolutely right. when a patient uses a medicine like furosemide for a longer time, it is likely that within a year, 2 years, the pharmacist provides a different packaging and different boxes. These are 4 boxes of exactly the same medicine. But if a patient gets these different types of medicines, of different types of boxes, and different types of information in the leaflets in there, they get confused. There's no way that somebody who gets these 4 different types of boxes realizes that they're exactly the same information and exactly the same tablets. The shape of the tablets differs. The shape of the information itself is not the same. It's just a mess. See that I've reached 20 minutes already. I'll quickly go back to the ibuprofen box I showed you at the beginning, the 200 milligrams ibuprofen with a hard to read silver background. This is the leaflets that goes with it, at least a detail of a leaflet. I've got to enlarge it very much to actually make it readable on this screen. But this is a top corner of this of a leaflet about ibuprofen. Again, there's many difficult typographic problems here. It's condensed type, it's printed in blue, the paper is too thin, you can see the background shining through. There is no line space anywhere. But let's try to read it. Basically, on this leaflet, you have got 2 lists of side effects. One list that is for absolutely serious side effects. You must stop taking the medicine immediately and go to the doctor. That's very serious side effects. But this list, as you can see in the top line, these other effects are less serious. If they bother you, talk to a pharmacist. So if your kidney failure or your meningitis or your heart attack or your stroke bothers you, you need to go to the pharmacist. You may need to go talk to a pharmacist. I find it strange advice. I really find it strange. If I have a heart attack, I really hope that somebody cares for me. And I don't think I'm able then to walk to a pharmacy to ask for advice. But what's even stranger is that ibuprofen is given to prevent headaches, to reduce fever, and to reduce flu-like symptoms. And those are exactly the side effects you can get from the medicine, from taking ibuprofen. And that means that if you have a headache before and the headache is cured and you get a headache afterwards, the headache might actually be caused by ibuprofen, or the fever might be caused by ibuprofen. I can't explain that, and Boots can't explain that either. So I've been talking to pharmacists what's happening here. And it's just unclear. Basically, it is there to cover the pharmaceutical industry from being sued against not providing the information, but this really does not help patients at all. And these mistakes are in every leaflet. I'm sure David Dickinson can agrees here that most of these leaflets have many of these side effects that are fairly difficult to explain, but also are fairly contradictory. A few more going downwards now. A few more slides. This is a leaflet for thyroid glands. Again, a person who's got difficulty with her thyroid, and it's a very clear blister pack with got a calendar on it. So you can see Monday, Tuesday, Wednesday on the top line. But this lady who uses these tablets ignores the information on the blister pack completely. She just does not follow the sequence on the pack at all. And I ask her, and she relates this with other medicines that she's taking. So she takes 2 medicines at the same time and makes absolutely sure that she takes them, but she presses both calendar packs at the same time. And that calendar pack is not designed for that at all. But simply asking patients, and by simply observing how they actually use this stuff in practice, you can learn how to design these things. Slightly more serious example is an infusion bag in a hospital, in a private clinic in hospital in Brussels. It's given to, it's a breast cancer chemotherapy. 1 in 7, 1 in 8 women have to go through this very brutal therapy, and they will get a Baxter infusion liquid like this. And can anybody see the name of the medicine? It's called Taxol or Toxal. the pharmacist of this clinic didn't have time, or if not interested enough, or doesn't care very much about patients, and gives the information in handwriting. And we have to hope. The patient has to hope that it is correct. Name of the patients I've clearly deleted out, but if you are a patient with a breast cancer, you get this, then the trust in the medicine and the trust in the treatment simply goes down. I've got literally hundreds and probably thousands of photographs like this of poor medicines information that actually doesn't work. I'll show you a few examples that are slightly better to make a bit of a balance, but it's still difficult to find good examples. This is a medicine, Semsia, for arthritis people. And people with arthritis have got difficulties with their hands because basically the joints are getting stiff and painful. People with severe arthritis can use this self-injection medicine. The ring at the end can be taken off by hooking it on a pen or something and taking it off. The shape of the injector is in such a way that with severe malformed hands, you can still inject yourself. Instructions in the packaging can be opened. It's a book-like opening that you can slide your hand under the top cover. It's completely designed with patients and for patients. Of course, this box, as you see it here, is about €1,000 or $1,000. So you actually can design something reasonable for that. Another good example, I think, is the insulin pens by Novo Nordisk. These are actually linked to Bluetooth. These are pens for children, and they are linked with Bluetooth to a internet. That means that the parents can actually follow if the child has injected themselves with the right dose. It records it and sends the injection to the parent, and that actually makes family relations a lot easier, and it helps children to actually be more independent when they're young. It's only for diabetes type 1, of course. Some more examples. This is a package leaflet that's given to patients with in hospitals that have pancreatic cancer. It follows actually the sequence of the package leaflets. What is it, the warnings, how is it used, and the side effects, but in a way that, in a visual way. And we're still evaluating this, and patients keep this leaflet or this brochure 6 or 7 months after they've been treated, which I think is a sign that they appreciate this information. I haven't found a patient yet who keeps their package leaflets. I need to find this after the interviews that we do with patients afterwards. They've appreciated this information. I'll see what the next example is. Oh, this is another one. This is actually a treatment of a acute leukemia. The original was 70-page document in Word. A few hundred or 150 oncologists and hematologists wrote this Word document, and it's the protocol to follow to give which medicines are given to patients in the first 2 years of their illness. And basically what's happening, and that's very surprising, it's a tear-off block that oncologists and hematologists use, and they give the patient one of these sheets, and they draw exactly where a patient is in their treatment and say, look, in this whatever phase, you get these medicines and you've got to come to hospital these days, and this is my phone number if you need any help. The strange thing was we've been testing this, and the reaction of patients was, if you ask them information what's actually mentioned, then they say, we don't understand it really, but we trust the hematologist and we trust the treatment because it's clear and it is nicely laid out what will happen. But I don't know what exactly will happen, but I trust my hematologist that he will follow this process. So it's a matter of not about information, it is about a matter of building trust between the patient and the hematologist that's improved here. So next thing, of course, we gave them a few cartoons and make sure that the patient is happy that he got some information from their specialists. I'm talking way too much. One other example is I've got 2 more slides. This is information book for children under 12 years old who want to take part, who are asked to take part in clinical studies. So it's given out by the hospital, and that's why we can do whatever we like and design whatever we like. It's given to children and is talked through with a nurse who says, look, you're in hospital because you have a particular disease, a cancer in this case, and we want to involve you in scientific research. And if you say yes, if you approve, but of course the parents are legally responsible, but if you don't involve the children from the start, they don't know what's happening. And most children in that time, from 7, 8 years onwards, know really, really well what's happening with their bodies already. And they need to be treated like vocal human beings, not like children where the parents have to sign a long document to take part in the clinical study. We've been testing this for now 2 years, and it's changing continuously. It's a very nice project to work on. And the last slide, this is the European legislation at the moment for packaged leaflets. So for these awful long leaflets is changing at the moment. It should have been changed last August. It should have been changed. They've missed the deadline. It should have been changed last week. They've missed the deadline again. And the first draft will be published hopefully soon. But one of the things that I'm doing at the moment is make a bibliography of the European packaged leaflets. There's about 400 articles in total have been published since 1992. And I'm just reading them, collecting them, putting them on a website to make sure that all the information is available. And the nasty thing is that I have not found a single article out of 400 that's positive about packaged leaflets in Europe. Not a single one. So that needs to change. Thanks very much.
Hey, Karel,
I think I'll stop here.
Yeah, thank you very much. That's extraordinary. Has anybody got any questions? Nothing's appeared in chat yet. Otherwise, I could start off with a question. Martin, you've got your hand up, please.
Yeah, I have a question about what I understood to be the compulsory consumer testing of patient package inserts in European Community. I understood that this had to be done and that leaflets had to meet a certain standard, something like 80 to 90% success. Otherwise, the leaflets couldn't be issued. Is that outdated information? Is that all wrong?
No, absolutely correct. Very briefly, the legislation was introduced in 2004 that every leaflet had to be tested. And the test was based upon the work by David Sless in Australia. That has to be done on 20 people, 2 groups of 10.
Mm-hmm.
And out of David Sless set the standards of 90% of the people who read the information must be able to find it. And out of that 90% who are able to find it needs to understand it. That's the original level, and that's in the readability guideline. That has been understood by the European regulators as, okay, that means that 16 out of 20 people must be able to understand the information in the leaflet. Which is, Veronica has done these tests, David Dickinson has done these tests. We've all been fighting with these regulations because 16 out of 20 means that 4 out of 20, 1 in 5 people, is acceptable that they don't understand it, which I think is a ridiculously low level for medicines information. We should, for some information, it should be absolutely 100%. Do not drive or do not take this stuff when you're pregnant. That should be understood by 100% of the pregnant, by the patients who might be affected. So yes, all these leaflets have been tested, but it has not led to an improvement over the last 16 years or the last 19 years at all. The leaflets are still as bad as they were, and probably even worse because they have been increased in length. The average length of a leaflet at the moment is 2,200 words, which it's and at the conference yesterday and the day before yesterday, I can get any leaflet through this readability test. I can write a readability report about it that is positive, that everybody understands it. It depends on the type of questions you ask and the type of people you interview.
But Karel, just going back to this point about if you're pregnant, don't take this medicine. If 4 out of 20 people can't understand that, then how can you write it or present it better so that 100% of people will understand it?
It's a brilliant question, and Sanofi would love to know the answer. They're sued at the moment because they have a medicine called valproate, and they should have warned people since 1985 when they introduced it. They've known that the medicine causes birth defect and brain damage, and they've been selling it since. And they put now a symbol, or a pictogram, or a logo on it, a pictogram of a pregnant lady with a slash, a traffic sign, red circle, red slash, pregnant lady behind it. And they asked me to be an expert witness in their court case to say, if we put this pictogram on the packaging, would have really reduced the risk of pregnant ladies, pregnant women taking this medicine. In England at the moment, 50 women, 2023, 50 women that are pregnant are taking valproate and can deliver in a few months' time babies with birth defects. There's an enormous chance that happens. The problem is that if you put a pictogram on a packaging, that's far too late. The prescribing doctor should have that on their screen. Do not ever, don't even think about it. The pharmacist should never ever dispense a medicine like that to a woman, to a woman who might be pregnant. And then if you put a pictogram on the packaging itself, you in fact blame the patient by being so stupid that they take it despite the pictogram. And that's just a completely wrong way of thinking. We should make absolutely sure that doctors and pharmacists do not ever give this medicine to pregnant women. And that means that the system needs to be set up. It's not the physical information that we provide, but it's the system needs to be, the prescribing system needs to be absolutely prevent this. The strange thing is valproate is extremely effective against epilepsy attacks and high levels of stress. So it is a very good medicine. But only one group should be excluded completely. And that needs to be very clear in the prescribing information that doctors should have when they get a patient.
Veronica, did you have a question?
Sorry, does it answer your question, Martin?
Sorry, Martin.
Well, it does. The only other point there is the problem that the doctor or the pharmacist might prescribe the medicine to somebody who isn't pregnant, or the doctor will prescribe it to somebody who isn't pregnant, but that doesn't exclude the women who can become pregnant while they're taking it. And I don't know whether the birth defects arise from that as well, but that's an extra complicating factor. It's almost as if you've got to say, well, we're not going to prescribe this to anybody, any girl, any woman between the ages of 13 and
50. Yeah, but at least that should be the warning for prescribers and pharmacists. It's an interesting issue. But Sanofi has been fined last April for 400,000 euros for one family, and there's 12,000 families in France only. So it is a very serious matter.
Okay.
Sorry, Veronica?
Thank you.
Yes, actually interesting to pick up on that. That might actually be an incentive for people to rethink, or for companies to rethink taking the compulsory testing seriously, because it's been around for, I think, since 2005, and nothing's effectively changed now.
Nope.
So maybe the court cases provide some sort of incentive. No, but there was one point I wanted to pick up on, the pictogram that you mentioned. There were tests done on the understandability of this particular pictogram of the crossed out pregnant woman, and it was actually interpreted as a birth control device, as a birth control
Mm.
medication. So it's hugely important that information design is taken seriously in this context. But I don't think there is much of an incentive to do that beyond legal action that costs companies a lot of money.
That's it. Yeah, that's a fundamental issue in the legislation, as well as the attitude of the pharmaceutical industry. They're in it for the money, and as long as it's legal, and as long as it makes a profit, it's okay. They don't care about patients, and you can see that in the 50% adherence and the poor instructions. If you replace the word adherence or compliance with medicine treatments with profit, then it's brilliant, because you sell twice as much for half the effect. And patients go back. It's a very cynical way of looking at it, but any article you read about how patients do not take their medicines, it's fantastic. Can't be better. We sold that stuff anyway, and now they don't take it, so they have to come back and ask for something stronger. Wonderful, can sell it again. And that's what's happening. And I mean, if you look at medicine cupboards of your parents and grandparents, that's where the profit of the pharmaceutical industry is. If you give them decent instructions, and absolutely instructions that work and help, medicine cupboards will be empty. And that's we need to look at that. We can't afford going on like this. It's not sustainable.
Karel, this is a cultural issue, isn't it, in the industry that sorry, Julie, I'll come to you in a moment. Your hand went up just as I started speaking. That if you think about something like the aircraft industry or the railway industry, they're totally driven by accident analysis. You know, they develop because there's an accident. Nobody wants to get on a train or a plane, and they go to obsessive lengths to find out what happened in that accident and to prevent it happening again at huge cost. Somehow with medicines, these pharmaceutical accidents are happening all the time, but it doesn't make us afraid to go to hospital. And perhaps it does actually, but
it should.
You know, we still pitch up in a way that we're not afraid of. We might be afraid of flying, but this culture of accident prevention doesn't seem to be there, which is extraordinary in a health industry.
Very, very briefly, it's true. When a lot of people, pharmacists, doctors, are all aware of the issues of the security and the safety, but nobody's responsible.
Yeah.
So if a patient unfortunately dies because of an overdose, did the patient make a mistake? Did the pharmacist give the right medicine in the right dose? Did the doctor prescribe it in the right dose? Was the medicine actually correctly delivered into the box? Who's responsible here? And they all point to each other.
Yeah.
And that means that is the doctor responsible? No, of course not, because the patient gave him wrong information during the consultation. I mean, who do you blame? And that's the because in railway industry and airport airline industry, you have every passenger can be seen as similar, and in the healthcare industry, it depends on individual patients, and it depends on individual situations. I mean, even during a lifetime, a few months difference might make a complete change in medicine prescribing behavior. So everybody's aware of it, but the one who's responsible is unclear.
But maybe we need to arm patients with better defense mechanisms for finding out.
Yeah, that will be a good start.
Yeah,
but the issue is one of the things that we can help patients with is decent information.
Yeah, yeah.
And the legislation actually actively prevents that.
Yeah.
So it is.
That's extraordinary. Julie, I want to go to Julie.
Sure.
She had a hand up, please. You need to
unmute us.
Okay.
Hi. Thank you, Karel. That was amazing. I knew already about some of the aspects, but that was really deep insight and is somehow disturbing. And I was wondering, it's really disturbing. I was wondering, as you teach, and not only Switzerland, but also in the Netherlands. No, in Belgium. I was wondering, you're near, somehow near the EU, and there must be some interest of the EU, if not of the governments of the European countries, to do something about it. I mean, we have the new Bauhaus thing running, and the EU wants to make people think about what is missing and what should be done about problems. So I think we would all appreciate if something would be done about this. And my question is, do you have some ideas how we as a EU, as a huge group of people who will all eventually take medicine, how can we do something about the visual quality?
One thing that I've been pushing the legislation and the legislators, and I've got a fair amount of contacts within both regulators, the European Medicines Agency, as well as the European Commission, so the commissioners and the all on a personal basis, because I'm not a European organization. Maybe the BIDA, the Design Association, maybe the IIID, maybe a few other organizations would be helpful. But the main issue is the lobbying group of pharmaceutical industry is a fairly large group of, the last count was what, 1,400 professional lobbyists in Brussels only. And the legislation at the moment is changing or is being revised. And the FPR, which is the European Federation of the Pharmaceutical Innovative Industries, basically the big pharma, is pushing every day to make sure that they get enough funding. It's a money thing to do clinical studies in Europe. That's the whole reason to change the legislation. The articles about patient information, as far as I know, have not been touched. So that's one of the reasons to this bibliography. And the articles that come out of that is that, look, guys, the last 30 years, you haven't listened to any evidence at all. The standard templates and the standards that we've used are ineffective. The readability guidelines and the guidelines that you've submitted from the European agency are as good as useless because they have not had any effect. The user testing that we've done in the last 19 years, since 2004, has had no effect whatsoever on the quality of the leaflets. So can we please reconsider? Can we please talk about the 5 to 15 billion leaflets every year that are binned and wasted? I think these arguments are strong enough to convince designers and convince people who are not interested in the shareholders and the money. But the industry, all pharmaceutical industries, on the conference yesterday and on Tuesday, have on their website, we work for patients and we are sustainable. And I raise my hand to say, look, you don't work for patients, you work for money. You're not sustainable, not even close. You just keep gluing plastic to aluminium in your blister packs. And with all respect, that's just a complete waste of materials. You can't recycle any of it, it's glued together. And they're aware of it, but the profits are so nice that before we change anything, they're all retired and rich. So what's your problem? It's a very cynical way of looking at it, but it's just...
Is there maybe one company where you would say they are really cutting edge, they are looking into the future, they would be like David compared to Goliath? If they would do something about it, the others might follow because they are so cool and everybody wants to have their medicine.
Yeah, of course. But I work together with many of them. They take Novartis, Roche, Novo Nordisk. One company, Novartis, one medicine is really innovative, uses half the materials, patient support is fantastic, digital information is absolutely amazing. Small product, whatever it is, 5,000, 10,000 users in Europe. Great. They advertise that all over the place. And then you go to the next door, to the next product manager, to the next product, who's in there for the profit. It's the pharmaceutical industry. The largest industry is 2.5% or 3% of the market. There's hundreds and thousands of companies who actually make money this way. And none of them is big enough to change the whole system. It's all,
okay.
So we need to do that.
Did you read this book by Malcolm Gladwell in maybe 10 years ago or so, Tipping Point? What has to be done to, you have it.
Yeah.
You know, I'm thinking about what is needed. I mean, the problem is so clear. Nobody likes to go on with this shit.
No, but it's on the other hand, if the whole thing is correct today, then I've got to find another work to do. It'll take a long time, but it's I think worth fighting for. But I haven't found a way. I haven't found a way yet to do it. And Martin, what he says in the questions, ideally the leaflet would be shorter. But if you had more pictograms or pictures and more explanations, would it not become longer? Yes, but that's right. If we keep all the information in the leaflet, but it needs to be a combination, I think, of paper information with absolute most important information, and digital information that provides the rest. And if it is a complex medicine that needs a very complex treatment, or very complex instructions, then the leaflet is not sufficient, absolutely not. But it needs to be a complete book. But why, if you buy the simplest hard disk, you get a complete book with it. But if you buy a medicine of the same price, you get a leaflet that's not even worth half a cent. So it's a balance in cost and what patients actually want and need. But it comes down to what I said earlier is if we give patients good instructions, the profits go down. So,
do you think, Karel, there's a role for what you might call support groups? You know, where particularly with serious conditions, there are often charities and patient groups who perhaps could get involved with producing sort of customized patient information.
Yeah.
One of the problems, obviously, you sort of alluded to, is that when you're ill, you don't feel like reading. When you're under stress, your cognition is sort of up in the air, isn't it? I mean, really, everything's against you. You're really trying to be rational, but you have carers, you have people who care, you have families. Saskia, yes, please. You've got some good comments in the in chat. Please come.
Thank you. Actually, I just wanted to chime into what you just said, with especially rare diseases and patient advocacy type organizations, because I'm an ambassador for one of those types of organizations. And what you see is that actually these organizations are actually funded by Big Pharma. And any work that they do on making the information more accessible to their fellow patients then sort of gets, ripped off on the cheap by the companies if they pick it up.
Yeah. Don't you want it to be ripped off in a sense?
You do.
Yeah.
Yeah, but it's this, awful circle where you'd want these, patient advocacy organizations to almost make a stand and force a change in legislation. But at the same time, you're dependent on the medicine and you're stuck in this vicious circle because you can't boycott it because you need it to, to treat whatever you've got. It's a very interesting conundrum.
Veronica.
Yes, and I'd have effectively you're doing the work that pharmaceutical companies should be doing. Yeah, they get the profits, you do the work, and it gets ripped off all over the place. So there's a huge yeah.
Nice that this is recorded. Great.
It's okay, you can broadcast. Quite happy to stand by that. It's pure imbalance of us against, what did you say, 1,400 lobbyists, pharmaceutical lobbyists in Brussels. But who listens to those lobbyists? It's our politicians. It's the people we are voting for now. So it takes more than one group to.
And the thing is, we only can do is and that's what's also not allowed at the moment. Make prototypes to show that it's possible to improve the information. So all the 3 examples I showed, sorry, it was 3 Dutch examples. I mean, that's absolutely correct. It's easy to hand. Now I will be working on those, so I can actually, I can understand them. I struggle with the other ones, but it's not allowed to make prototypes and test them without any clinical studies. So that's one of the things that we run into with the delirium brochures that we are designing now for Matthias Schleukel in Zurich and in Glasgow. How can we introduce them into medical practice without going through the clinical and ethical committees? We just want to give brochures to family members of people who have a delirium.
Martin, you've got one question.
Yeah.
We want to make this the last because we're coming up against our hour. There's people who'd like to carry on.
Well, just perhaps a slightly flippant point, but I do understand the merit of creating prototypes and showing demonstration projects. I remember doing that very thing back in 1981, and it was one of the first rewriting jobs I did, was to show how we could have a better package for things like Benylin and Night Nurse, which are, basic remedies. Published those in a book called Writing Plain English. That's back in 1981. So this is a very long furrow that we're all ploughing. Good luck with it, Karel. Good luck with it.
Hey, look, thanks very much, Karel, for a really stimulating talk. I'm sorry more people weren't here for it. We've got much lower numbers than normal for this talk, and I think we just didn't spot that it was next to Easter, and people have gone on holiday. Some have told me, but it's been recorded, and I hope others will log on. I just want to mention a few things coming up. I mean, very relevant to this is the Vision Plus Conference on Health Information Design, which is going to be in Vienna, 25th and 26th of May, organized by IIID. So the website is, Veronica, is it just Google Vision Plus? It's visionplus.iiid.net. Yeah. And just before that, we're having our next summer school, which is going to be a 3-day event in Vienna leading up to that conference. Go to the Simplification Center website. The next talk in this series is also very relevant to what we've been talking about. It's by Sheila Pontis, and it's on user testing for information designers. She's written a great book on field research for information designers, and so she's going to structure this really as a question and answer session. So if you join that, she will just briefly introduce it, but then we're hoping people coming will all have questions about how would I test this, how would I test that, and perhaps we could give her the task of how would I test this pharmaceutical leaflet. And I mentioned the summer school on the 17th of April. Go to the same website, simplificationcenter.org.uk, and we're doing a preview of the summer school for anybody who'd like to come to it but doesn't know much about it. Julie, you've got your hand up.
Yeah, Karel, I would like to suggest you give this talk again and again everywhere, and please, yeah, please in all the academies and universities, and in the German Bundestag and in the Parliament of the EU. This really needs to be spread. What you found and what you see.
I do my best, but it's at the moment, 2023, I've got 8 talks till now, and I've got about 4 or 5 conferences to go before August. Okay. So I do my best, but
you know, the good thing is it's also funny. It's disturbing, but it's also funny. So
Not funny.
why not go to TV and you know, it's entertaining also.
It's entertaining. It's not funny.
Karel also teaches on the summer school, as Thomas and Matthew are aware. Good to see you guys.
And so if you wanted to come to the summer school and sort of think more about this in depth, even run a project on it. So and the websites, Veronica's put those in chat if you want to find out more about the conference and about the summer school. So hey, thanks for coming, everyone. Have a good Easter weekend if that's your thing, and it'd be lovely to see you at future events like this. So again, thanks very much, Karel, for a really stimulating talk. Slightly alarming in terms of.
Sorry about that.
Yeah. I always feel you ought to have more hope for the future at the end of it. But there we go. Yeah.
Great.
Okay. Well, we'll say
Thanks,
goodbye.
Karel.
Thanks a lot.
Thanks, everyone.
Nice
Bye
seeing
then.
you.
Thank you.
Bye.
See you soon.